Perfect. Okay, I think we're there. So thank you very much for having me. I was here in 2023, and since then we've done quite a lot of research, developed our team a lot to be able to deliver this type of treatment. And I think, as Susanna said, it's a really good time to explain where we are. I'm really pleased to see, I didn't know who was coming this year, but there's a very mixed bag of people. Oh, there's Nicola. So actually, there is a patient here who had TILs therapy within the first trial that we did in 2019-2020, who's been all the way through it. There are patients who are going to have TIL therapy in the coming weeks, within the next month, which is exciting. Well, perhaps that's the wrong word, but we'll go through it. There are patients here who've had TIL therapy on trial with us and who've actually been hugely motivated and gone to Israel to have TIL therapy at the Sheba. So I think you're going to get a full panel of patient experience, which would be super helpful. But I also appreciate there'll be people who might be here and saying, well, what's TIL therapy at all? And so I have to make the talk a little bit broad, if that's okay. And whilst it might be sort of, some people will know a lot about this, others will know very little. So I've got about half an hour to go through things in kind of a broad amount of detail. I'm sort of starting with this slide, which I always put up to frame any melanoma discussion. And of course, this isn't relevant to everybody. And I'm not going to sort of go through trial after trial in this talk, but this is just showing you that if you receive, this could be Nivo-Rela, but this is ipilimumab and nivolumab for metastatic melanoma. And we know, it's a slightly broad statement, but roughly half of patients with skin melanoma that receive ipilimumab and nivolumab go into long-term remission or have long-term cancer control, which is fantastic. And that is fantastic if you compare it to other solid cancers like colorectal cancer or breast cancer when it's spread around the body. But the reality is when that's you in the clinic room or if that's your relative, having a 1 out of 2 chance of being well in the long term isn't good enough. And that's why there's a huge amount of effort to try and expand the number of people that for whom we can derive long-term cancer control. We're really motivated still to try and use the immune system because it seems to be that approach that gives you the chance for long-term cancer control. And one way of using the immune system that I'm sort of focused on is cell therapy, as Susanna mentioned. And there are different types of cell therapy. This is our cartoon sort of simplifying some of them, some of which you might have heard of. CAR T cell therapy is a standard of care in types of blood cancer and lymphoma. There's an approach in the middle called T-cell receptor therapy, another cell therapy which is actually approved in a type of sarcoma in the US. And then we have TIL therapy at the bottom, which is what we're going to focus on today. And I'm mainly going to focus on lifileucel TIL therapy, which is the name given to the first approved TIL therapy, approved in the US and Canada for metastatic melanoma. Why is TIL therapy an option for patients with solid cancers or advanced melanoma, advanced lung cancer, for example? Well, the obvious reason we can do it is that these tumours are solid. So leukemias are a tumour of the bone marrow, it's liquid. Lymphomas are cancers of the lymph nodes, but they're liquidy tumours, and you can't take lumps of tumour away and make a treatment. Whereas for solid tumours, these are solid structures, we can do a surgery, we can remove some tumour, and we can make a treatment bespoke to the patient from their tumour. This is actually a lung cancer, not melanoma, and it might not project very well, but within there, what you have is a tug of war going on between the immune system and the cancer. And so what we do for TIL therapy is we start by doing a small surgery to take a piece of tumour, and from that, we take out and expand up the potential cancer-killing cells, the T cells or TILs, which stands for tumour infiltrating, so going into tumours' lymphocytes to much higher numbers before giving them back into the body. But it's a very complex process that's very highly regulated because this is a living treatment. It's not a drug. It's actually living cells exerting their activity bespoke to each patient. And so it requires a whole team and infrastructure to be developed to deliver this sort of treatment in research and outside of research. And on this slide here, all of these people are actually none of them are surgeons, it's all of our team. And some people in the room might just about recognise some people. So myself and my old research fellow Max are at the back there. We have Kim, one of our research nurses, Lauren, one of our other research nurses, and two biological specimens coordinators. So these are people who are used to coming to theatre or clinic and collecting blood or tissue, cancer tissue, to do research. And so it's a big pathway that takes a lot of people. And because we have to protect the health of the tissue, because from it you're going to derive a treatment, and everything needs to be done under sterile, temperature-controlled conditions, we need to be able to demonstrate a whole trail of our work to show that we've abided by the relevant regulation, nothing's gone wrong, everything's temperature-controlled. And so it's a steep learning curve for hospitals that are new to this, and it won't be available, it will only be available, at least to start with, in sort of specialist centres who've developed the infrastructure to do this. For TIL therapy, what we want, which we don't usually want, is as healthy tumour tissue as possible, because if you have healthy tumour tissue, it's most likely that within it you're going to have healthy TILs, healthy T cells, that we're going to expand up to higher numbers. And here we took this ellipse. It may not project well, but you've got skin at the top there with a stitch. Underneath it there's a bit of fat, and within it, I know they look a bit like teeth, but they're not. This is healthy tumour tissue. And that goes off to a manufacturing facility, and I'll talk you through the pathway in a little bit more detail. So this is a specific pathway for lifileucel, but it would be very similar at the Sheba or elsewhere. This is a sort of standard SOP for making the treatment in its simplest form. So you start with the tissue on the far left. That tissue, under the very controlled conditions I mentioned, goes into a flask of media, which is just solution that supports the health of that tissue. It goes off to a manufacturing facility. In the manufacturing facility, you add a cocktail of things that promotes the expansion of those immune cells, those T cells or TILs, up to much higher numbers. And at the end of a 3-week period, you end up with, pretty reliably, with many billions of TILs. What's variable, though, at the end of it is how many of those will be true tumour-killing cells or have the potential to be. There's no sort of selection step for those cancer-killing cells, partly because we don't perfectly know which of all of these many cells in the tumour are going to be cancer-killing cells. But you hope that amongst those many billions of TILs, you've expanded up some of the cells that will go on to be cancer-killing cells to much higher numbers than at baseline, and reinvigorated them a bit so that when they come back into the body, they're in better shape. The next step is to come into hospital, and you actually have some preparative chemotherapy. So not chemotherapy to kill melanoma. We know that most often that doesn't work very well, but it's chemotherapy to prepare the body and prepare the sites of cancer to be more receptive to the TIL therapy. And the type of chemotherapy is called non-myeloablative lymphodepleting chemotherapy, which is a bit of a mouthful, and it's shortened to this, NMALD. And just to talk you through that, the non-myeloablative bit means it's not killing the bone marrow. This is not leukemia, so we're not trying to get rid of the bone marrow that makes all the blood cells, but we're temporarily dipping it down. But it is lymphodepleting, meaning it's getting rid of lymphocytes, which are the composition. TILs are a type of immune cell called a lymphocyte. And if we leave all the lymphocytes as normal in the body, they will be competing for the same food, if you like, or growth factors to persist in the body. So the chemotherapy eliminates all of the circulating immune cells there, or T cells, so they're not there as competition. And it also conditions the sites of tumour to be more receptive or to increase the chance that the TILs can effectively act on the tumour. And the next step is to give the TILs. So I should add that for us, the chemotherapy we give as an inpatient, we do that for a couple of reasons. There is an increasing move in treatments that are already approved in other cancer types to try and give that sort of treatment as an outpatient. But this is high-dose chemotherapy, first of all. Most patients with melanoma will never have received chemotherapy before. And so there's some uncertainty about how well it'll be tolerated. And there's a practical element too. You know, we have a fantastic public healthcare system, but we don't reliably have free beds. And, you know, if you have this chemotherapy, have a fever in the middle of the night, call the hospital, there's no bed, you know, it completely sabotages the whole process of trying to give you this treatment on time and look after you properly. So we keep patients in for the chemotherapy. which is about a week before. And then on the day of the TIL transfer, the cells arrive on the ward in a liquid nitrogen shipper, so they're still frozen. They were frozen at the manufacturing facility in Philadelphia. They come over, they're thawed at the bedside in a water bath, and then they're put up as a drip. And that's normally pretty uneventful. Occasionally you might have an infusion reaction, but that's less common. That bit's normally pretty uneventful. It's the next part where things start to add up a bit. And so at the time of having the TILs, the chemotherapy's done its job. It's wiped out the other immune cells in the blood, more or less. So the main cells ticking around in the blood now is the TIL therapy. And then, to help it better get to work, we give something called interleukin-2, which is something that's going to promote the expansion of the TILs that have gone into the vein and their activity. And that induces fever and shivers and rigors and causes inflammation within the body. And that is the storm, if you like, that period of time where you may be developing fever, rash, the blood counts are low as a consequence of chemotherapy. That is the slightly messy part where you have to look after patients as a clinician very carefully. After a couple of weeks, or a week or so plus following the chemotherapy and the TIL transfer, slowly, after the chemotherapy, the body starts to wake up again, the blood cells start to come back up, the fever starts to settle, and you start to feel a bit more human again. But it's tough. And I'm not going to talk to you about how tough it is, but I'm going to let Matthew and others explain their personal experience and how they found it. The next slide I just wanted to put up, I'm not going to go through clinical trial after clinical trial, but I just want you to understand the history of what's happened. And well, TIL therapy's been around for decades, actually, but if we just start with a more sort of modern era, of trying to give TIL therapy to patients who've received modern-day treatments that many of you in the room may have had. This was the C14401 study, and we opened this in 2019. And Julia, who's here somewhere, was one of the only patients, one of 3 patients we treated in this study. And it's important to say that because of Julia's contribution into this research study, this treatment, lifileucel, is now a standard of care in North America. That is the impact that you can have as a patient. So I've told Julia this on the phone or in person lots of times, but she has directly impacted hundreds, potentially thousands of patients with melanoma by contributing to this study. You don't need to read all the text on here. I didn't put the slide up to do that. But this is a study of lifileucel TIL therapy when all standard treatments have stopped working or worked for a bit and stopped. And this is a slide that's supposed to show the characteristics of the patients that went into the trial. And this sort of slide is put up because it's hoping to show you that these patients in the trial more or less reflect the real world. That's not always the case, and one of the big criticisms of this trial, probably because there were quite a few US patients in it, is that there were patients that received between 1 and 9 prior lines of treatment. I have no idea how somebody received 9 lines of treatment, and it's bizarre. There's nothing that's evidence-based to give 9 treatments, but this is being criticized in the sense that I think it's correct that some of the data that's come from this may not be completely applicable to the real world. And actually, one would hope that in the real world, and I'll show you some data for this, if you use this earlier, it has a much higher chance or a higher chance of working. This next slide looks very dull, but tells you about how the treatment works. And the overall response rate is the number of patients with shrinking tumours, significantly shrinking tumours, and it's about 1/3 of patients. And whilst that doesn't sound good, it's worth saying that in the last 5 to 10 years, no other treatment in the setting where all other treatments for advanced melanoma has failed has made that sort of impact. That wouldn't be much of an impact if that effect didn't last for long. But actually, the median duration or length of that response, when this slide was first written, hadn't been reached. And so the longest standing duration of that response when this slide was written, and I have an update here, was 38.5 months. And I'll show you that. That the great thing about TILs, although in this setting it's for a minority, not majority of patients, it does offer a second chance potentially at long-term melanoma control. This slide is a so-called waterfall plot, and every rectangle is a sum of the size of the tumours that are being measured on the scan. If the rectangle is going upwards, the tumours are getting bigger. If the rectangle is going downwards, the tumours are getting smaller, and it's in percentage, you can see. So if it's 100% negative, it means all the tumour is gone. You've had what we call a complete response. And so you can see what we call the depth of some of these responses, really good shrinkage in many patients who went into the study, and complete responses amongst these patients here on the right in green. The blue are what we call partial, so excellent shrinkage, but not complete resolution of the cancer. And importantly, for a number of people in the room who will appreciate this, the asterisks are for patients whose melanoma carries a BRAF mutation, because we know that for these patients who might have melanoma getting worse despite BRAF targeted therapy, that can be a very sort of aggressive disease course and very difficult to get into trials. But actually, you can see how well a number of patients were doing on this treatment with BRAF mutant melanoma that was getting worse despite all standard treatments. The next plot is showing you how these responses evolve over time. And the upside down blue triangles show you that at 6 weeks, it's weeks at the bottom, scans at that time, in contrast to checkpoint inhibitors like IPI, Nivo, Opdualag, and so on, 6 weeks is a pretty reliable indicator of sensitivity to the treatment. The green triangles show you that even as far out as 24 months or so, we could see patients going into a complete remission, and that these responses could be durable. Side effects are important, and they're not always well captured in the way that research trials are reported. Here, the AE stands for adverse events, which is trial speak for side effects. And on the bottom, you've got time, you've got months. And hopefully you can see that there's this big peak of side effects on the far left side. And the nice thing about TIL therapy is that it is aggressive, but almost all of the worst side effects occur in hospital during the 14 to 21 day admission when you're under direct supervision of the medical team. You're not coming in and out at month 10, 11, and 12 with colitis or other side effects you might get with approved immunotherapy. And so it is a sort of one-off, one-stop treatment, which is very attractive if it works and does the job that we want it to do. I wanted to show you, though, and this is with Matthew's consent and Zoe's consent on the next slide, how some of the side effects look. And I'm just hoping, is the sound off for the slides? Could it be? Otherwise, I hear my own voice, which is difficult to listen to. Thank you. So I'm going to show you a couple of slides of interleukin-2. That's the treatments after the TIL transfer. Induced rigors or shivers is quite scary. I don't think it's always reflected in these sort of videos. The heart's beating away, the fever goes high, you might appear a bit breathless. You'll all be used to oximeters that you have to check the oxygen levels in the blood. That's dipping down. And this interleukin-2 induces a state a bit like sepsis that has been a bit more in the public domain. Blood vessels become leaky, you get high fever, and so this is a time we have to be very careful about looking after patients. And as a general rule, you need to develop experience as a clinician in looking after these sort of side effects. The general rule, though, is if you give up to 6 treatments with interleukin-2 over about 4 days, if the side effects from the previous dose haven't settled, we omit the next dose. If you omit 2 doses in a row, we tend to stop. And those are pretty good stopping rules and helpful for people who are learning how to give this treatment. But Matthew, without further ado, sorry for this. this is Matthew. Can I see that? Is it playing? Yeah. I don't know how well that projects, actually. It just looks like you're lying in bed from here. Hopefully it does. But shivering away, feeling a bit rotten. The grimacing is because you were having some hip pain, not to do with the actual TIL therapy. But that's Matthew. This is Zoe. Zoe came up to us from Dorset Way, from Rachel Plant. And both Matthew and Zoe have been in the different trials, but first-line TIL therapy trials. So TIL therapy is a first treatment for metastatic melanoma. But I mentioned the interleukin-2 treatment induces more systemic inflammation. That's Lauren, who's my sort of nursing partner in crime. And Zoe also developed rash. so dermatitis over the skin. She also developed inflammation at the back of the eyes. So it's a tough treatment to sort of get through. And as I said, we'll go through that together with Matthew and others in a tick. But because of the data that I showed you, since February 2024, the FDA, the US body, have approved lifileucel as a treatment for melanoma that has progressed or got worse despite standard treatments. It is a conditional approval, and they're waiting for some extra data from some other trials that are ongoing. But what we have had most recently, since last summer, is 5-year outcome data. So how well are patients who were treated in the original study that Julia was treated, and how are they at 5 years? And this is a bit nuanced, and I'll go through it with you. So this is called a swimmer's plot, and it's showing you, again, a bit like the bar graphs, that show all of these lines are patients' tumours, or the sum of them. If they're going upwards, they're getting bigger. If they're going downwards, they're getting smaller. All of these are patients who originally responded, and you can see most of them are staying in the minus, which is good, going all the way up to month 60 there, which is great. There were no late side effects captured in this kind of long-term follow-up data, but there are survivorship issues from lots of different perspectives. There's definitely a group of patients who are tired a long time after having this treatment, sometimes years afterwards. And other things that I think, if we have this outside of trials in the real world, will become more apparent. With the chemotherapy, that type of high-dose chemotherapy is already used in the hematological cancers, blood cancers, and we already know that that could impact your fertility at those sort of doses. That could put you into a premature menopause. That could increase your chance of a second cancer. So there are definitely survivorship issues, as exciting as this sort of treatment is. There's slightly, it's my job to be measured about things, because I'm very optimistic and very passionate about trying to bring this treatment and new treatments into the clinic. But at the same time, how well does the treatment really work? When it's your relative, you would do anything to get them into this study or get this treatment if standard treatments haven't worked for obvious reasons. But it's a tough treatment, and overall at 5 years, it's 20% of patients from the original group who are alive, not 80. And I'm afraid it's not, and of course, remember, these patients are heavily pre-treated, and maybe not perfectly reflective of our UK population, but nevertheless, it's 20, not 80%, and not all of these patients are still have in response from the lifileucel. It sounds a bit confusing, but it's actually only about 10% of patients who've had a good response and remain well at 5 years. And Julia is an example of that. So when Julia came to us for the original trial, she had lung secondaries, as well as some melanoma in the head and neck area. The treatment that she had eliminated the secondaries, but she has lived since then with persistent melanoma. So so just to explain, not all patients alive at 20 years are in remission, if that makes sense. Why am I saying all of this? I'm saying all this because I'm a bit concerned about what analysis in the end will NICE make about all this from a health economics perspective. It would be better from my perspective if they, if the trial could have been a little bit cleaner and more reflective of a modern day population. My comment though about giving the treatment earlier is that in the US it's approved. And this, again, you don't need to read it. But in the US, when they've looked at the patients so far they've treated in the real world outside of trials, the response rate is nearer 45%, 44%. And that's our experience too. The earlier you use it, the better. That goes for most treatments, of course, but this is still in the setting where all other treatments have failed, and then you give it, but you're just giving it a bit earlier. You haven't had 9 treatments before. And there's more data to support this. So in addition to lifileucel, there was a big effort from Danish and Norwegian colleagues to do a TIL therapy study. Very impressive. They made the TILs in-house. They had carefully developed manufacturing facilities. This group of patients was a bit different, though. When they started the study, in Scandinavia, they give a lot of pembrolizumab or nivolumab on its own as treatment for melanoma, and they still do. And so when they started the trial, patients with metastatic melanoma, they had nivolumab or pembrolizumab on its own, And if it didn't work, they could go into this trial, which was TIL therapy or ipilimumab. It was randomized, so a computer chose what they got. It was really, really struggling to get patients in, enough patients in, and then the after surgery, the adjuvant treatments were approved with pembrolizumab or nivolumab, and then they started to put patients in who'd had that treatment but relapsed despite it. And they ended up with this sort of data that showed you the response rate, the number of people with significant shrinkage was 49%, and they'd only had one prior line of treatment, so it was much cleaner. They also selected patients according to a blood test called LDH, which can be a surrogate for the sort of biology or behavior of the melanoma. The higher it is, typically the more aggressive melanoma tends to behave. And this is a curve of what we call progression-free survival. And what it means, when it flattens like that, as it does after about 28 months, I think I can see from here, it means that none of those patients who are on this, there are patients on a line here, none of those patients are having cancer getting worse. And so in that setting, it was somewhere between 20 and 30% of patients that looked like they had long-term cancer control as a consequence of this treatment. But we've also done other research studies here, giving pembrolizumab, the checkpoint inhibitor, or the standard immunotherapy with lifileucel in patients who haven't had any treatment before for their melanoma. So they haven't had adjuvant immunotherapy, they haven't had immunotherapy for advanced melanoma, and they come and have the surgery, one shot of pembrolizumab, and then the inpatient admission, the chemotherapy, the lifileucel, the IL-2, and then the pembrolizumab carried on. And then this was the data, which we're writing up now. There are 22 patients there, not 102, so you have to be a bit careful about the percentages because everything looks a bit inflated. But hopefully you can see a lot of downward rectangles there. And the response rate here, giving it in that setting, was 65%, which is super encouraging. A lot of complete responses, so everything disappearing on scan in the green, of about a third of patients. So that was super encouraging. And these responses have been, and we've seen them, we have patients in the study durable, which is fantastic. And Zoe, who you saw, or sort of saw, having the rigor in the middle there, this was her baseline scan. I don't know if you can see, but there's a lung metastasis on her right lung on the far side there. And this was her scan at 6 weeks. That and other sites of melanoma had disappeared, and she's been in remission since the 6-week scan, which is fantastic. But she is living with some survivorship issues. She's still a bit tired. She's not 100%. And this is some time since the treatment. So I just need to be balanced about all of this. Because of all of those trials that have gone before, we now have the TILVANCE 301 study, which is a first-line trial of TIL therapy plus pembrolizumab in patients that could have had prior immunotherapy in the after-surgery or adjuvant setting, but the melanoma has to have relapsed greater than or equal to 6 months after completing that treatment or stopping it. And this trial has been criticized a little bit, mainly because a computer decides if you get the TIL therapy plus pembrolizumab, lifileucel, or pembrolizumab alone. And for most of us, pembrolizumab on its own, we wouldn't necessarily consider that a standard treatment anymore. So it's quite difficult to find a situation where patients are definitely suitable for this. Matthew went into that study, and we've had other patients go into this study. And it is very powerful for some patients who are motivated to get TILs. Matthew has mucosal melanoma, and actually there looks like there's a good signal for mucosal melanoma with TIL therapy, with lifileucel. Because of this trial and how it's designed, we have to match up scans at the same time for patients having pembrolizumab on its own or lifileucel plus pembrolizumab. They have to be synced. And it's been a bit odd for us because we've had Matthew and other patients in hospital, and they've had to have scans 7 days after the TIL therapy, which would seem far too early, and we wouldn't really know what to make of those sort of scans, and have warned Matthew and other patients about, we're not really sure what we're going to see here. But this was one of the first patients we treated on the study. And again, I'm sorry if it may not project very well at all, but hopefully you can see there's something measured there. I don't know if you can see this, but at 7 days, this isn't 7 days between the scans, but that's a baseline scan, and this scan is 7 days after TIL therapy. And this lady, who had received adjuvant nivolumab after surgery, developed stage 4 melanoma in the adrenal glands, both of them under the skin, has been in complete response since the 7-day scan after TIL therapy. So this is a super powerful treatment potentially, 7 days and into complete remission. And then this is Matthew, this is you. And again, I'm really sorry it doesn't project very well, but this is the liver, this big grey splodge there. And hopefully you can see there are some calipers on there. There is something measured, a slightly darker patch below it. And that is a secondary in the liver. And this is Matthew's scan, again, 7 days after treatment, and you can barely see it. And that is the great thing about Matthew's scans now, is that we can barely see anything in the liver. We certainly can't measure things properly. And every scan we do, things are improving. So potentially super powerful treatment. Because of all the criticism I've mentioned about the number of prior treatments, we have this study at the moment, where a bit like the Scandinavian study, you can have had one prior line of treatment, of immunotherapy treatment, and then go into the study where everybody receives a TIL therapy on its own. And Nicola, who's over here, is in that study and going to have treatment in the coming weeks. And so, just to finish, how do I see it? I'm really excited about TIL therapy, and I've shown you how powerful it can be. 7 days complete responses. It's absolutely fantastic. But who really needs it? Because it is tough. It's unequivocally tough to go through. And I don't know why I'm just skipping ahead. Sorry. And for some patients, if you choose the wrong patient to have this treatment, it could shorten your life. So you need to carefully select who's fit enough to have it. But when I say who really needs it, well, who could actually get away with less aggressive treatment? For whom is this going to be over-treatment? And ideally also, for who is it going to work and who may it not work? And we really do need to work that out. As I said, it's tough going, and so selecting who should have it is tricky. If this comes through to the NHS, we will have a sort of national meeting to help support patients and help support clinicians about who should really be receiving the treatment. It's definitely attractive to use it earlier, as I showed you. And I think there's a lot of room to make it kinder, to make it better, and with any type of immunotherapy, to get the immune system in as good shape as possible so this works as well as it can or better than it currently does. There are long-term sequelae, I think, and some survivorship issues that will become more apparent when we use this in day-to-day life, all being well. And where are we in the UK? So the MHRA, our regulatory body, need to license this as a treatment in the UK for us to have any sort of access anywhere for it in the UK. And that decision keeps on being moved slightly, but is expected in April or certainly by the end of May. And we will have a final decision by NICE in August 26. I don't know what that will be. It is worth saying that almost every single cell therapy for hematological cancers has been declined or turned down by NICE first time. And so that this keeps skipping ahead. Sorry, I'm not sure what's going on. Every single cell therapy for hematological cancers, which are now standard of care, have been turned down at first. So there may be some appealing that we need to do. And as I mentioned, we have these trials open at the moment. Trials can be a bit precarious. I had a meeting yesterday which is a bit concerning about one of these trials, and I'm not sure about the future of it. But whatever we do, at the moment we're trying to provide access to this treatment for UK patients through the trials. If trials fall away, we will try and find another way of bringing TIL therapy to patients. Whatever we could, in some way, we'll work it out. And I'll stop there. And I think we're doing questions after the next bit. Thanks very much for listening.